Hi, my name is George Nicholson. I'm one of the Pediatric Cardiology Fellows at Children's Healthcare of Atlanta, Emory University. And what I'd like to talk to you today is give you a brief introduction to the most common congenital heart lesion, excluding a patent foraminal valley, that affects approximately 3% of the general population. That is a bicuspid aortic valve. I have three objectives at the end of this introductory talk that I hope we will be able to accomplish. First one is to define what exactly is a bicuspid aortic valve. Secondly, I'd like for everyone to walk away with knowing why is this important to know and how can I diagnose this disease. Simply put, a bicuspid aortic valve is an aortic valve that has two instead of three leaflets, and there can be fusion of any two of the three leaflets. As you can see here on the right hand portion of your screen is an MRI picture of a bicuspid aortic valve, and on the left is of a tricuspid aortic valve. And what you can see, besides for the obvious that a bicuspid valve has two and the tricuspid valve has three leaflets, is that the effective orifice during systole, or the amount that the valve opens up, is different between those individuals who have a bicuspid versus a tricuspid valve. And this will play an important role, as I mentioned later on in this talk, regarding the things to watch out for and why this is a clinically important disease entity. So why is this important? We know that people with a bicuspid aortic valve are at an increased risk for stenosis of the aortic valve, whether this is a congenital aortic valve stenosis or acquired stenosis, as those individuals with a bicuspid valve are at increased risk for calcification of the valve leaflets. We know that if you have one left-sided heart lesion, you're at an increased risk for another left-sided heart lesion, such as coarctation of the aorta. So this is an important disease process that you have to evaluate for in any individual, especially newborns who present with this disease process. Individuals with the bicuspid aortic valve are known to be at a higher risk for dilation or an aneurysm of the ascending aorta. And as you can see here on this 3D MRI reconstruction, if here's the level of the aortic valve with your left ventricle here, this is your ascending aorta to your transverse arch, and then going posteriorly and inferiorly is the descending aorta. And as you can see, the diameter of the ascending aorta is drastically different than that of the transverse or the descending aorta. And we know those individuals with bicuspid valve are at increased risk for regurgitation of that valve itself. And a nice little mnemonic to remember these four key points by is SCAR, because if any of these are clinically important and affecting a patient's quality of life, that's what they're going to end up with on their chest. Now, as I mentioned on the previous slide, it makes sense that if you only have two instead of three leaflets, all right, you're at an increased risk for stenosis of the valve. And the same can be said for why there is increased risk of regurgitation of the valve. What a lot of people get confused about is why is there ascending aorta dilation? And although there are a few theories, a key component to this dilation is the abnormal flow velocity across that valve. And on the left-hand portion of your screen, you can see an MRI picture with flow velocity mapping, and that is of a tricuspid aortic valve. And you can see the velocity and the flow is nice and laminar as it goes up the ascending aorta out across the valve into the transverse and the descending aorta. And what you'll notice here on the bicuspid valve, or the picture to your right, is that there's an eccentric jet across that bicuspid valve leading to swirling in the ascending aorta. And over time, this leads to dilation of the aorta itself. Other arguments for dilation of the ascending aorta are that people with a bicuspid valve have an inherent aortopathy or an abnormal wall architecture itself, which also leads to this dilation of the ascending aorta. So how can you diagnose this disease process? As most people are asymptomatic, and as I mentioned previously, if it affects 3% of the general population, that's a substantial number of people. So you can rely on family history. If there are other direct family members who have congenital heart disease, obviously you're going to be screening those family members. However, more commonly, we have to rely on our own ears for a diagnosis. This is a normal first and second heart sound. As opposed to someone who has aortic stenosis. There's a large, harsh systolic murmur, oftentimes classically described as best appreciated at the right upper sternal border. Versus someone who might not have stenosis, what you can hear is a systolic ejection click. And it's okay if you're not able to say, okay, here's S1, here's S2, and I have a systolic ejection click that is early, mid, or late in systole. The key point is, I just want people to be able to pick up on that it is not a normal first and second heart sound. It is an abnormal heart sound. And oftentimes, just being able to recognize the fact that it's abnormal will then lead you down other further diagnostic testing, such as an echocardiogram. So in summary, an aortic valve that is bicuspid has 2 instead of 3 leaflets. This is important because people with bicuspid aortic valve are increased risk for stenosis, other left-sided heart lesions such as coarctation of the aorta, increased risk for aneurysm or dilation of the ascending aorta, and also an increased risk for regurgitation of that aortic valve. And again, based on auscultation, this systolic ejection click is classically described as associated with bicuspid aortic valve. Thank you for your time and your attention, and I hope this helps.